Good afternoon, everyone. Thank you so much to all of you for making time to join the webinar and for registering to come and hear about the release of our interim report for the Productivity Commission's inquiry into delivering quality care more efficiently. I'd like to begin today by acknowledging the traditional owners of country throughout Australia, from wherever you're joining. For me, it's the Wurundjeri and Woiwurrung people. For my colleagues in the Canberra office of the Productivity Commission, it's the Ngunnawal and Ngambri people. I'd like to acknowledge their continuing connection to land, to waters and community, and pay respects to people, cultures, elders past and present. My name's Alison Roberts. I'm joined today by fellow Commissioners Angela Jackson and Martin Stokey, as well as our Assistant Commissioner Katie Bradbear, who led the team for this inquiry, and valued members of our team, including Billy, who's helping us with driving the slides, and Katie's assisting with the Q&A. It's my privilege to open the presentation today, but at about the halfway mark, I'll be handing over to my colleague Angela. We thought we'd spare you three separate presenters in a short presentation, but Martin is here to assist us both also with questions at the end. So just to give you a bit of an overview of where we're at in terms of the inquiry process, you may be aware that this inquiry is part of a broader 5 pillars of inquiry that the Productivity Commission has been tasked by the Treasurer to undertake. There's been a bit of discussion in the media about this with the Economic Roundtable next week. So all of the inquiries are collectively striving to make really practical and implementable recommendations to the federal government to ensure that our domestic policy settings support economic growth and resilience through gains in productivity. Our task as part of that has been to focus on the care economy. And we have been fortunate to have great engagement through our consultations so far, a huge number of responses to our various modes of engagement, from submissions to short survey responses. And we're really looking forward to the next phase, which is to receive submissions in response to our information requests that are inside the interim report, as we work then to finalise our recommendations to government by end of year. So it's fair to say that while we all value high quality care, we're going to need it at some stage in our lives. It supports our well-being, our dignity, our ability to live active lives at various life stages. The care system is under increasing pressure to deliver high quality services, but at a sustainable cost. So, bit of background on why this is a challenge. So firstly, the care economy is growing. As this slide shows, the workforce has more than doubled over the 20 years to 2020. Care contributes 8% of Australia's GDP and an estimated 12% of the workforce. Many of you joining today might work in care, whether paid or unpaid. Focus of our inquiry is on that paid care sector. We're also seeing that the shares of these are going to continue to grow, as you can see from the projections out to 2060. So improving productivity in the care economy is challenging because it's necessarily labour intensive. It's challenging to deliver more care services per caregiver without risking constraining that important personal interaction that are essential in delivering high quality care. So unlike other sectors of our economy, market sectors, improving productivity in care is usually about improvements in quality, so delivering better quality care rather than more or cheaper care. It's not like producing different outputs. However, quality is not captured in our traditional measures of productivity. When we do account for quality, we can see that productivity growth can look different. And we see that in some parts of the health sector, for example, productivity is actually growing by 3% a year, which is far outstripping the growth in productivity in other parts of the economy. And we also compare quite favourably when we look at other countries as well. But despite these improvements, the costs of care keep on rising. And so that means we are getting better outcomes, so through that better quality, but not necessarily for a lower price. So what do we do about this challenge? How do we face this challenge? This is what we were tasked to look at through our inquiry. And we've identified 3 areas for reform, and they are all focused on delivering that quality care, but doing so more efficiently. So we've tried to look across reform areas that cut across what we say is the siloed nature of care sectors. That is, they are all delivered by different departments within government and different sectors and don't always talk to each other. So a common theme that we kept hearing was that care is fragmented, yet it needs to be able to respond to our increasingly complex needs and overlapping needs. We often need to access care services from a variety of sectors, services from health to disability to aged care, for example, and to be able to draw on those services in a way that's not confusing or challenging for the people who are trying to use them. So we've identified 3 opportunities for reform. The first of which is to reform quality and safety regulation to support a more cohesive care economy. So as I mentioned, that where the systems talk to each other better and can reduce some of the waste and duplication, to embed collaborative commissioning to increase the integration of care services. And we'll talk a bit more about what that actually is, but it's about parties coming together to work more effectively to reduce gaps and deliver better quality care. And then finally, investment in the establishment of a national framework to support better government investment in prevention. So I'll now take you through the first of those reform areas, and that is the reform of quality and safety regulation to support a more cohesive care economy. So we know that across care sectors and jurisdictions, so between the states and territories, regulations vary even for very similar services. Governments can have separate processes and systems for administering these regulations, which creates these silos and a disjointed regulatory system. We've also had a number of reviews, some of you might have participated in them, and royal commissions that have resulted in a swathe of very sector-specific reforms and regulations. And these have been necessary, but they've added to an already complex system. So if we have a look on the next slide, we know that the costs of misaligned regulation, or as I said, those systems that don't talk to each other, can fall on the users of the care system, their carers as well, workers, providers and government. But ultimately, it's the users of the system who pay the ultimate price because it reduces the opportunity to deliver high quality care and reduces the ability to navigate an increasingly complex system. In our engagements, we heard, for example, from some providers that the costs of duplication in compliance and administration can really add up quickly. So we heard about having to complete 15 separate accreditation processes across health and social care services, for example, despite the fact that the services that were being delivered were basically the same sorts of services. And then for workers, we know that having to undergo separate screening processes for each sector or program or jurisdiction in which they work can actually cost money and delay access in paid work. So why this matters is that these high administrative costs, both in terms of time and money, can lead to providers actually withdrawing some services or deciding not to enter into new areas of service. And all of that adds up to less choice and less access for people who are trying to access these really important services. So in our inquiry, we heard from, these are just a couple of examples of the many submissions that we had, what this actually leads to. So you can see examples of inappropriate or unregulated use of certain practices. We also know that there's inconsistencies and the duplication that I mentioned before. And this really undermines what is the purpose of having these safety and quality regulations there in the first place, which is to lift the quality of services that are delivered. When we look at how the workforce and providers operate, we can see some opportunity here. So there is quite a bit of overlap in the way that many providers operate across multiple sectors, and this presents an opportunity to work better together. So what can be done? We see that we have a long-term vision for regulation across all care sectors and jurisdictions to be aligned to the greatest extent that is appropriate. So as a first step, we say that government should focus on aligning regulation across 3 areas, so aged care, disability and veterans care sectors. And that's because there are similarities in these sectors and, as you saw on the previous slide, an overlap in providers. So we say that over the next 6 years, the Australian government, through collaboration with states and territories where appropriate, should implement a suite of actions focused on firstly aligning worker regulation, provider regulation, and then aligning the broader regulatory landscape across aged care, NDIS and veterans care. We're hopeful as part of this that the fact that we now have at a Commonwealth level a single department that looks after health, disability and aged care will be an important facilitator in this process. As you'll see for those of you who've downloaded the report, and if you haven't, it's available on our website, We then have questions because this is an interim report. So we are seeking information on the following areas. And we have some questions in there. I won't go through them today because I want to allow time for questions at the end. But we have questions in areas like performance reporting, the pros and cons of a single regulator and some of the things for us to consider there, and also around the benefits and costs of alignment in behaviour support and restrictive practices. I'll now pass on to my colleague Angela Jackson to take us through the other two reform areas. Thanks, Angela.
Oh, look, thank you so much, Alison, for the introduction, and great to join you all today. Thank you. 357. This has to be one of my top ever webinars, so fantastic to see this level of interest. And I would also like to acknowledge that I am currently on the lands of the Wurundjeri people and pay my respects to the elders past and present. So Alison has gone through sort of the motivation for this piece of work, and also the first reform area, which is in some ways at a sort of a micro level. And as we're looking at breaking down silos, we've sort of thought about it conceptually as well, what's the micro type reforms, and then the second one around collaborative commissioning is a bit more meso level, so organisational level, and then the final reform area around intervention and early intervention and prevention is more the macro level. So collaborative commissioning, what do we mean by collaborative commissioning? And Billy, I'll get you to go to the next slide. I think it's good to start there. Definitions are always important in any speech, and to make sure that we all understand what we're actually talking about. It's not just procurement, it's not just about contracting, it's actually a lot more than that. What we're talking about is where organisations come together to do joint needs assessments in a local area to identify what those priority needs might be in terms of service delivery. They do joint planning to coordinate how those needs are then going to be addressed. Then we get to procuring and the delivery of services, informed, of course, by co-design and really talking to their local communities and the service users. We then need, obviously, data, joint monitoring and reporting with very, very clear and robust outcome frameworks before we evaluate to support that accountability and inform changes. Now, collaborative commissioning is not a new idea. It's in the National Health Reform Agreement as something that PHNs, that's primary healthcare networks, and the local hospital networks should be doing, and is one of the reasons why we focused on that relationship in particular, because it's not necessarily, and this whole reform process isn't about trying to come up with brand new massive reform ideas, but it's really about, well, what are the incremental changes? What are the things that are blocking some of these productivity improvements across the care economy? So we had a look at particular at this relationship, and why it matters in particular is that we know that that integration between the primary healthcare system and the acute hospital system, and that lack of integration is creating gaps in our system. We hear that time and time again, and Alison mentioned, fragmentation is well recognised as an issue across the care sector, but particularly in the healthcare sector. It creates discontinuity of care, so for patients in particular with chronic conditions who are moving between the systems, it can mean that they're not getting the comprehensive care that they need to keep them healthy. The transitions between different sectors, we see that people, whether they're in hospital, so delaying the discharge in hospital between the NDIS and the aged care system, for example, can mean that people aren't accessing the services that they need. And we see this real inefficiency occurring. So whereby, lack of access to primary healthcare needs leads to avoidable hospitalisation and additional costs and resource use. So for us, this was really an area where we could see that it's been identified as an area that something that should be happening. It's an area where if we could get it happening more systematically across the system, we could see real improvements. But there's obviously something that's been blocking it. So what is it, and what are the reforms that we need to put in place to see it actually happening on the ground? As I said, there are plenty of examples of where it has been occurring, and so some might say, well, there you go, it can. And they're really, really exciting examples of where it's been occurring, and there's a collaborative commissioning program in New South Wales that's funded a lot of pilots across New South Wales, some really good examples of joint needs assessments leading to activities which better targeted elderly patients in the community and really reduced hospital admissions. Brisbane North PHN was often held up as the exemplar when you have these these discussions, and there's been some fantastic work done there around complex care coordination within GP practices, leading to significant savings, and the Birthing in Our Communities program, where we can see, you know, some really important strides being made in terms of the closing the gap in terms of preterm births and birth weight. So we can see how it can definitely work. The question then is, well, why isn't it happening? And what we really heard was that, number one, for it to occur, you need strong leadership and really engaged leadership at both the PHN at the LHN level. And the reason for that is because often there's a sense of working against the system rather than the system working with you. And so that for collaborative commissioning to happen on the ground and in reality, it requires a lot of investment and commitment at the local level. It's not being supported by the system, both in terms of the way in which funding works, the way in which governance works, and the incentives in the system at the moment aren't supporting it. And so our, I guess, goal or our aim therefore was to think, well, what are those reforms that can ensure that the system itself is supporting it? And we break those sort of reforms into two areas. So this is really about embedding collaborative commissioning. So it's not just the exemplars, that it's business as usual across the system. The first is around governance. And governance is often seen as a little bit boring, a little bit bureaucratic, but really, really important. So we want to see LHNs and PHNs, like, to do collaborative commissioning well, they have to identify needs and they have to plan together. Without that first step, you don't get the collaborative commissioning. So joint needs assessment, agreed plans of work, and agreed evaluation of outcomes. We also need to see LHNs and PHNs working well with and effectively with local ARCHOs. This is not about, and ARCHOs in many ways are a bit of an exemplar in this space already, but in terms of the partnerships between ARCHOs, who are obviously providing services to Aboriginal and Torres Strait Islander communities, but not necessarily the entire Aboriginal and Torres Strait Islander community within a region, that link up occurs between mainstream services and ARCHOs through joint partnerships and planning and just shared decision making. And that's going to involve some capability uplift across the board as well, and stronger requirements for collaboration. So again, formal joint collaborative commissioning committees in terms of governance and that data sharing, which we see as being critical to the overall governance process and particularly evaluation. The next part, of course, of the picture is funding. There are often barriers put in place to the pooling of funding, either at the Commonwealth level or at the state level. We want to see LHNs and PHNs have more flexibility over which allow them to actually work together. So where there are those barriers, that they be removed. The resourcing of this joint governance. So we accept that, yes, while there are existing funds available, there is probably going to be a need for some additional funding in this space. And dedicated funding. So when plans are done and there's programs identified, that there is a process that or plans are identified, programs that may deliver savings and improved outcomes, that there is a process for additional funding if required. Now, in terms of the size of the prize, I think, you know, primarily in terms of the productivity, as Alison alluded to, in the healthcare sector, we are really interested in better outcomes. So whether we save actual dollars in the budget or not, we want to see better health outcomes. And we know that this has the potential to really reduce hospital admissions, preventable hospital admissions, which do save money. Now, the reality, of course, of unmet need across the health system means that there's probably going to be someone else ready to use that bed. But what that means is there will be better health outcomes for the millions of Australians suffering chronic conditions, improved outcomes for Aboriginal and Torres Strait Islander people, improved workforce participation through those better health outcomes. And we can see over time that innovation and information about what works and what doesn't can lead to improved productivity as well across the activities being performed by local hospital networks and PHNs. Again, we have a few questions. I won't go through them around governance, funding and implementation, but would really welcome feedback from everybody online today through the submission process. I'll give you the dates right at the end of the presentation. The final area, my final 4 minutes, and I have gone over, and I apologise about that, so I'll try not to rush through it, but is a national framework to support government investment in prevention. People on this call will be well aware of the importance of prevention. Now, in this space, we're not just talking about public health prevention, we really are talking about early intervention across the board, whether it be in child maltreatment, in homelessness, disability, in health, in early childhood education and care, where we spend money today to save money into the future and to have better outcomes into the future by stopping problems evolving and avoiding future costs within the system. We see this as key if we're going to lower that trajectory of increasing care costs, the graph that Alison showed at the start of the presentation. It's not just about saving money, of course, it's about better outcomes. So if we invest today and we improve the future health and well-being of our population, well, that's a huge productivity benefit overall. So there's clearly a need for prevention spending if we're going to lower this cost, but there are barriers to that investment. And those barriers are multifaceted. They involve a lot around the silos that occur within government and between levels of government. And overall, Australia is one of the lower investors in prevention, and this is a health prevention statistics, so not that broad a measure, but the only one that we actually have statistics on. So we'll show it and show that we clearly underinvest when we compare to comparative countries like Canada and other OECD countries. What we identify as being, I guess, some of the barriers are that those benefits and costs are often misaligned. So there might be a cost in the health portfolio, but a saving in social security, or the cost might be in a state homelessness service, but the benefit might be in federal health spending, vice versa. And so those costs and benefits being misaligned means that the people making the decisions or putting forward the spending proposals are not necessarily the same people who are going to benefit from that spending. Short-term thinking. We work in budget cycles that are 4 years long maximum. We have election cycles that are even shorter. And what we often see is that prevention benefits can take years to manifest. And in fact, sometimes the costs or the outcomes can appear to deteriorate initially before they then improve. And budget process simply don't facilitate that. And then there's the evaluation gaps. So there can be a lack of clear linkage between the activity, potentially the short-term lead indicators, and then the long-term outcomes. And that creates, I guess, an information deficit, which makes it harder for decision makers to be sure that what they're investing in is actually delivering the outcomes that they were promised. So we've heard a lot about these barriers across the board. Again, one agency or jurisdiction may bear the cost while another reaps the savings. And that's really the framework by which we came at this problem. We know that there's been attempts to do work in this space before. They've been relatively narrow health focused. So we've sought to broaden that out. They often also tend to focus only on one level of government. So again, we've been rather ambitious in thinking that by creating, and we can go to the next page in terms of what our recommendations are, a national prevention framework, which at its core has a prevention framework advisory board that we would see would work with the same sort of, I guess, rigor as a PBAC type board in terms of providing real evidence-based economic evaluation approaches towards assessing and advising on prevention investments across the board in Australia. And our aim there really is to elevate prevention, I guess, in the national policy framework, and to provide it with that authority piece by which people can have confidence to bring together the different parties for the collaboration that's required. And that's both across the federal government, but also interjurisdictionally between states and the Commonwealth. The idea here would be state governments could bring forward proposals, so could the Commonwealth. They could be evaluated. The benefits would be assessed in terms of, yep, this is cost effective, and the benefits accrue, say 20% to the state, 80% to the Commonwealth as an example. And then that would help inform how some of these proposals might be funded going forward. So again, we have a number of questions around evaluation, funding and implementation. Really, really keen to get feedback about, what people think would work and what wouldn't. Funding in particular, maybe there'll be people on this call who have particular views about what maybe works together and how it might work with existing programs funded by states and territories in particular, or whether we should maybe consider alternative approaches in terms of governments of the framework. So in terms of inviting feedback, we've got submissions that are now open, that they'll close on the 15th of September. We really, really want to hear from people. So please come forward and give your views. It can be as short or as long as you like, and we'll have our final report provided to government by December 2025. So thank you very much. I feel like I'm out of breath because I've had to speak so fast, but we got it done, and look forward to answering some of your questions.
Okay, hi everyone. My name's Katie Bradbear. I've been the Assistant Commissioner on this inquiry. Thank you for sending through your questions. We've got some great great ones coming through. So why don't I start off? The first question comes from Dr. Jane Tiller at Monash University. And the question is, given the need to boost productivity as quickly as possible and the longer term drivers relating to prevention, what timeframe do you expect the recommended national framework to take to set up? The argument is that setting up this framework will actually delay the introduction or funding of productivity boosting preventive interventions. And so how can we get going on increasing funding of preventive innovations that are already shovel ready while we get this framework set up?
Look, I don't think this framework stops any good idea from being funded by a government if it can go through the current process. Obviously, part of the issue that we've got at the moment is, yes, we have a short-term, issue in terms of productivity being low, and we want to lift it. But we really do need to get the architecture right. And unfortunately, there isn't much we can do in terms of, we don't have this prevention advisory function within government at the moment. And so I think establishing that for the long term is an investment worth making. I guess, and I get the urgency, but I also think we need to be willing to take the time to get some of these reforms really embedded and to get them right, because the payoffs won't just be in the next 2 years or 3 years, they will be intergenerationally, and the challenges that we face are intergenerational challenges.
Thanks, Angela. The next question comes from Vera Wayatunga. The question is, so far, what findings have there been on how digital technologies like automation and AI can boost productivity and outcomes in the care economy?
Oh, that's a great question. One of the we've done, the Productivity Commission's done a bit of work on this in the past, but obviously it's a rapidly evolving space. There are obviously a lot of areas in health where digital technologies and AI are being taken up at a rapid pace. Those of you who've seen a doctor recently might have seen your doctor using AI to assist with note taking, for example. There are also opportunities, and this is particularly pertinent to some of the areas that we identified in some of that reporting burden that we spoke about. So where providers are having to produce very similar reports, the ability for AI to assist with collating the information and putting it in the right format for reporting to different regulators is obviously a productivity boosting, or certainly an efficiency gain there. So we haven't looked at that as a specific line of inquiry in this report. However, what we do say is we don't want that to be a new area, and this is consistent with our other report that the Productivity Commission's put out. We don't want it to be another area where we have separate regulations in the separate sectors. So while we've recommended that where there are existing regulations that are different about them coming together, we certainly don't want to see regulation of digital technologies and AI being another area where individual sectors set up their own rules. We'd rather see a holistic approach across the care sector if in fact new rules are needed.
Thanks, Alison. The next question comes from Andrew Koss. And the question is, the 3 reform areas that were suggested are the key ones and make sense, and great they remained in the interim report. But were there no others to add following the consultation to date? Interested to know if you found more distinct areas of consensus to reform.
I saw this pop up in the chat. It's such a good question, and my colleagues can chime in, but there were no shortage of good ideas when we first went out in the original productivity pitch. If you have read, and if you haven't, I recommend it, the opening report in the suite of the 5 pillar inquiries. You will see in that report we used a framework to help narrow down all of those great ideas, because one of the things to know about, for those of you who don't, about the Productivity Commission is that all our inquiries are done under terms of reference from the Treasurer. And one of the things that we were tasked to do was to look at practical and implementable reforms. And that is, of course, can be a challenge because things might take really long time frames. They might also need a bit more work to help build the evidence base for them. So they might have been proven up in a small cohort but need to show benefit across a wider scale, or biting off a bigger reform. And I think there was a question in there that related to this about you know, why haven't we gone wider, for example, in the collaborative commissioning? And I think it's related to this as well, because one of the things that we tried to do with our approach was to ensure that we chose a starting point that would allow progress to be made where perhaps there were already elements of the architecture in place, or there was already a pathway for reform. In collaborative commissioning, for example, the National Health Reform Agreement midterm review talks about exactly this, about enabling the right funding and governance structures for parties to come together. Now, that doesn't mean we don't think that going forward, there is a role for collaboratively commissioning broader services across the care economy. In fact, that's exactly what our Aboriginal community controlled health organisations do. At a regional level, they plan and deliver and procure and deliver services across a whole spectrum of service delivery areas. So to wrap all of that up, there were a number of other great and big ideas. The other thing that we had to filter out was where there are other processes that are already addressing those. So other reviews that have been undertaken and have processes of implementation underway. A couple just to cite include, for example, the aged care reforms that are only just being introduced as a standalone piece, the Medicare review, the scope of practice review, for example. Sorry, I think I gave a very long answer to that and wrapped up another question.
Yeah, and I think there was one in there already. It's about NDIS as well, about foundational supports and the similar issue. Obviously, we're aware that the government is actively considering the NDIS review, and that for us, therefore, to come in wasn't going to be particularly helpful at this point. So there were a few restrictions in this space, but we still felt that really this focus particularly on silos and breaking down the silos, whereas an area where while there'd been a lot of sector specific work done, there hadn't been really this look across the care sector about, well, how do you dismantle some of these silos that's causing inefficiencies across the system.
I was just going to add, and Martin Stokey's my name. I'm one of the fellow commissioners, and very grateful that Alison and Angela have led the charge on presenting our findings. Just on the issue of additional ideas, all of the submissions are on our website and they'll remain available and published. They go to the department, and so they feed into future policy thinking, so they're not lost. And also, as an organisation, we've aligned ourselves into thematics, of which care economy is an ongoing thematic. So whilst we've written our interim report, we'll finalise that towards the end of this year. The ideas will potentially form inputs into our consideration and support going forward. So we don't think these additional comments and other areas are wasted in any way, shape or form. They're great ideas, and we welcome and encourage that. We just couldn't do everything straight away.
That's a great addition. Thanks, Martin.
The next question comes from Nadine Blair, and we're getting a few questions in on the prevention framework. This one is, how will determinants of health like housing, not just homelessness, be actioned under this framework? Also, will a new framework align with the National Preventive Health Plan, or is this a duplication of that work?
I'm happy to pick it up. So I think in terms of the determinants of health, and I did mention homelessness just because it's an example, but it was an example in terms of where you can spend money in one area and save in the others. The framework isn't so much, it's really about saying we want to have an advisory body that advises government around prevention action. So it's not about one thing or another, whereas a National Health Preventative Health Plan may well have spending under that or ideas under that. This is not what we're about. We're really about saying, okay, the budget process as it currently works doesn't properly consider prevention. As many of you may or may not be aware, the budget generally operates in quite a siloed way. So individual departments will bring up a budget bid. So the health department will bring up a bid. That will often have to be offset, and it will be offset within the health department. So it might save money, but it will save money within health, and that's kind of the way they do things. They wouldn't sort of claim to save money from education, for example. That would be that that would not get them very far. And the time frame over which that has to happen is around 4 years. There's also a limit in terms of some of what the benefits of that might be. So the second round effects is how we refer to it sort of in budget speak. So the idea really here is to have an advisory body that says, look, this idea that's this program will generate savings or benefits once we take into account the different areas of government and the different levels of government that outweigh the costs over a longer time frame as well. So, we're thinking, 20, 30, 40 years into the future, allowing it to take into account those second round effects, allowing it to take into account the improvements in outcomes, and it's a cost-effective intervention. And so what we think is that additional information for government that then feeds into the budget process will allow them to reorientate some of their thinking away from quite short-term acute needs and meeting those towards this longer-term view in terms of investing today to really save and lift productivity into the future. And as a result, lift investment in prevention across the board. And this is a year in, year out initiative that then gets embedded into the way government makes decisions. Evaluation is an important part of that because there needs to be an insurance process that it's actually delivering and back into the budget process. So I hope that answers the questions. It's not sort of saying fund X programs and you've solved the problem. We see this as really part of the architecture of the budget process and the way in which government invests, improve the decision making of government so that you have this long-term focus on prevention.
Thanks, Angela. And while we're on the prevention framework, I might just go to another one before we move to something else. But the question comes from Deanne McMullen. Why is there no mention of the Australian Centre for Disease Control? This is the natural home for prevention.
I'm happy to answer it again or to someone else. So we see this as broader than health. So we know that in using, and I raised one of the first things I'm saying, prevention, isn't that? It's a name, but we are talking broader than just a public health initiative. So we can think, for example, in the justice space, in Victoria, the Early Intervention Investment Framework, these are broader concepts than just health. And that's why we don't think its natural home is the CDC. That doesn't mean that some of the programs that are funded by this might not be, or might not be managed through the CDC, but in terms of as a body, it's not necessarily its natural home, that this is a broader cross-portfolio investment by government. I mean, it could also involve, for example, and I'm not going to say what I'm going to say, but income support payments, for example, could also be considered a form of early intervention, or the way in which income support works, for example, or there are different parts of budget that aren't necessarily primary healthcare focused.
So the next question comes from Simon Pryor. Can you please comment on how these reforms will improve access to care services in rural and remote communities?
Yeah, that's a great question, and one of the things that we've been doing in our engagements is talking with some of the work that's been already going on in regional and remote communities who have some of the best examples of actually collaborative work, because the services can be thin on the ground. So one of the challenges in doing that is the inability to pool funds and to share data where, for example, one service provider is a Commonwealth service provider and another is funded by the state, for example. Often they can't share data to see whether they're achieving what they're trying to achieve. And they also can't necessarily share workforce for some of the reasons that we identified at the beginning of the presentation, because people might be registered to work or in one area of work, but not across. So the ability for workers to move between sectors, which is particularly important where there's a smaller workforce, is something that we've looked at as well. The Commonwealth does have some trials at the moment around collaborative commissioning in regional and remote areas and the ways in which they would need to facilitate that happening better. But we also see it as a cross portfolio together with the states and territories as well. So that's one of the things that we'll try to get at with the collaborative commissioning. But if you have particular thinking on that, and this goes to all of the questions, we would really love for those of you who are able to send us submissions with your ideas. And I should say that the questions that we don't get to today, some of which have information in them or comments to us, we will keep those and consider them as inputs into the next phase of our inquiry as well.
I'll just add, Alison, that one of the core elements embedded in collaborative commissioning is a place-based perspective around what the needs are at a local area. So perhaps the prevention framework is a macro view, as Angela spoke about. The meso or the local needs assessment, particularly in remote and regional areas, the needs may be different. So finding ways to break through the silos in specific areas where those communities know exactly what they need, and that might be different in different parts of the country, and then being able to have the flexibility to spend the money to deliver to the community services. That's where we think the collaborative commissioning concept can be expanded. We've focused in our report around potential preventable hospitalisations between primary health networks and the hospital system. It equally extends very easily into, for lack of a better description, thin markets or remote and regional areas where government services apply themselves and the needs are specific to the local areas.
Thanks, Martin. I am conscious that we've reached the end of the time for the webinar, and I guess what remains, and thank you so much, and I'm sorry to those of you whose questions we couldn't get to. As I mentioned, they will provide really valuable inputs to our next phase of receiving information and considering that as we work towards the final report. Thank you so much for making time to be here for this webinar, for your questions, and hopefully this has sparked some thinking for you to put together, whether it's a short or a long submission. We'd love to hear from you by the 15th of September. And yeah, have a look out in the next couple of weeks for this webinar if you want to send it around to others and encourage them to respond to us as well. Thanks very much for joining us today. Thanks to colleagues and to the whole team.